Hello dear colleagues, dear friends, we are back with our online masterclasses. This time we will be showing you step-by-step direct composite restorations for anterior teeth, and there will be a lot of clinical and practical tips and tricks that I'm going to share with you with great pleasure. So, if you will have any questions related to the topic of today, please feel free to write down your questions under this video into the chat. And straight after main session, we will do live Q&A, and you will be able to get your answers for your questions, and we're more than happy to help you with solutions. If you have any questions related to technical issues like sound or video or something like this, please don't write these questions under that video. Write them into the chat where you have got your registration and booking for this online masterclass. The program for today. We're going to share with you questions and answers related to the color issues, how to match the color. Then I'm going to show you step-by-step layering process, how to place enamel, dentin, how to create enamel shell from the palatal side, and how to work with proximal contact points, and with the internal anatomy like mamelons, some internal effects. Then how to do lifelike polishing and finishing of your restorations. So I think that after this course you'll be able to do direct restorations in your daily practice in easy way. Before I start, I would like to point main problems that we as clinicians have during our workflows making our direct restorations. So the problem number one is color. How to match the color of our restorations. The question number two, or the problem number two, is how to layer properly the anatomy and how to create properly interproximal contacts. And the problem number three, how to create proper shape, form, texture, transitional angle lines, and how actually, in simple words, how to make our restorations lifelike or natural, how to make them like natural teeth. So this is what we are going to discuss today during this online masterclass. And I will start with the first problem, color. Let me be very clear. The color or shade is not that important as opacity, because some people, they still used to think that they are not selecting proper shade of composites. That's why their restorations look more gray, or they look more white or more yellow. The problem comes not from the shade. The problem comes from opacity. And I would like to give you a simple example. Let us assume that we have tooth A3. And logically, we take our composite A3 dentin and A3 enamel. According to logics, the result has to be perfect. But if you will place more dentin than necessary, your restoration will be definitely more white or more yellow, more opaque, and that everything will be visible. So you fail the game because of the opacity, not because of the shade, because shade was the same as the tooth. From other hand, if you will place in more enamel than necessary, you will have opposite problem. Your restoration will be more gray, more translucent, not enough opaque, and you will fail the game because of that. But if you messed up with a shade selection, and for example, instead of A3, you selected A2, but you placed enough dentin and enough enamel. So topography-wise, everything was correct in terms of aspect ratio between enamel and dentin as natural tooth has. In this case, from the social distance, nobody will see the difference. Everything will be perfect because of the opacity match. So what we have to do is to determine the proper type of opacity before we start the case, and then we go with proper layering of enamel and dentin. Let me show you from the microscope. We need microscope view. Let me show you initial situation. Here we have two central incisors. They were already restored with composite. This is what we are going to do. So when we have patient with necessity to do composite restoration, first of all we have to determine opacity type of the tooth that we are going to restore. How to do this? It is very easy. You take a look at the incisal edge, and according to this you can make a decision or conclusion regarding opacity type. So if you cannot see any translucency on incisal edge, that means you have high opacity type or low translucency type. Let me decrease the power of the light here. So I think that it will be better for you to see the translucent incisal edge. Let me go to the higher magnification. So again, if you don't see any translucency on incisal edge, that means that you have type like a high opacity type of patient's teeth. If you can see from 1 millimeter to 1.5 translucency, so this is bluish or grayish line here, you can measure it with a periodontal probe. For example, in my case here we have 1 or 1.3 millimeters of translucency. That means we have normal type of translucency. The case, normal type of translucency. Okay, and if you have translucent incisal edge that is more than 1.5 millimeters, this is high type of translucency. And it is obvious that in such clinical cases you will work with enamel and dentin differently. You will place more enamel in case where you have high translucency type and less enamel in case when you have high opacity type. So first of all, determine translucency type. That is the key point to get successful result. Then take picture. Okay, you have to have this picture in front of you when you are going to do restorations, because since your patient will stay with open mouth like 10 minutes or 15 minutes or more, the teeth will get dehydration and you may lose any color marks for yourself. So you will have to have some picture in front of you to understand the vertical component of dentin layer and so on. Another thing that I recommend you to do is just to determine simply the shade by using regular classic Vita shade. If you want, you can go more professional way, like you can create your own shade guides for composite that you are using, because you know that composite can be different from the Vita, despite the fact that it is written something in your composite tube, like for example A3, it may not be A3 with a Vita, for example, or it may not be A3 with another brand of composite. So you can create your own shade guides. There are special tools for that, but I like to make things simple, and personally I don't feel the shade guide, the customized or individual shade guides are super important in daily basis. The most important thing is to determine the opacity, then to determine roughly the shade by using the Vita Classic, and then you go with your composite. I prefer to go with natural layering procedures like matching topography of dentin and enamel as natural tooth has. And I also use dentin as in natural tooth, more saturated or more chromatic than the final shade of the tooth. In other words, if the tooth is A2, for example, I will use A3 dentin and A1 or combination between A2 and A1 enamel, and then I will end up with a good result if I will match opacity. Okay. Now let's go for silicone index manipulations. We will take silicone index from that restoration here, and then I will explain you how can we do the silicone index in case if you have, for example, tooth with trauma or half tooth missing or severe caries defect. So this is the thing that I'm going to share with you later on, but now let me take silicone index from initial situation. Let us assume we have easy case for palatal wall restoration. We have to understand, by the way, that palatal wall is super important to be restored properly, because palatal wall gives you orientation, gives you the map for dentin. This is what what is done by, yeah, here is better. This is what is done by palatal wall, so that is important to do properly. If you have teeth saved, preserved, you can do it from the initial situation. So first, we make a roll or small cylinder of your silicone. We need microscope view. Then you put your cylinder towards palatal side. You press. You go. Let me magnify so you'll be able to see incisal edges. So you go up to incisal edge. You go up to incisal edge. We cover all incisal edge, but we don't want to cover vestibular surface, so we keep our silicone in incisal edge. Let me show you that view. Yeah, so you can see that we have impressed incisal edges, okay? And we wait till silicone index will set. So now let me discuss with you what kind of clinical cases can be taking as an example like I do here in the Phantom. For example, you have patient with old restorations. The restorations are bad in terms of color, some discoloration, maybe secondary caries. So patient wants to replace this one, but there is good palatal wall, so we take impression straight away. Another thing is when you have patients with a caries defects, like class 3 caries defects, but palatal wall is preserved, so the main damage is driven from the vestibular surface. So you can take impression from the existing situation. But if you have patient with small defects like chipping of incisal edge or small caries defects, you can make freehand mock-up first. You just take your composite without etching, without bonding, you create some anatomy, and then you take silicone index from the patient's mouth. So you do some adjustments, like some reconstruction before with composite, no bonding, no etching, okay? And then you go with your silicone index. And then there are clinical situations when you have big defects, big, huge defects, like a trauma. The half tooth is missing, for example. Yeah, that's good. This is good one because we have reflected all palatal surface, and also we have reflected incisal edge. You see, incisal edge like this one. So we keep it. Now let's discuss cases when you have, for example, trauma. You have patient with a trauma, half tooth is missing. What to do? In this case, I'm going to show you now. After preparation, I will show you how do we fix the problem. Some people, they can do it freehand, by the way. They do direct restoration freehand. They are very talented. They can control the layers buccally and palatally, but it is difficult. So I prefer silicone index, but I will show you how to create silicone index after I will finish preparation. And then I can tell you another tip. Let me prep first, and then I will tell you some tips and tricks. How can we solve problem when we have a big defects, for example, or multiple defects to be restored. Now we need microscope view. First of all, let's check the tooth, the adjacent tooth. This one is like a reference for us. We have transitional angle lines. We can see highlights. We can see texture. You see the texture that we are going to do with you. So this is what we are going to mimic with that restoration. So let me now prep. Let's say, let us simulate initial situation. Not prep, but simulate initial situation. I will cut a lot. I will cut now half tooth. Will break proximal contacts, both of them, and I will show you how to restore proximal contacts. So we go up to the pulp. I'm kidding. I'm not going to the pulp. It's not a good option, not a good idea. I'm making very extensive defect, huge effect. I'm making just for demonstration, okay? Just to show you many tips and tricks. So if you know how to do big defects, you will be able to know how to do small defects. if you are interested in how to reach the pulp correctly and do endodontic access, we have another online masterclass. It is in our web platform, the endodontic access, so you can see that. But now I'm making a very big defect. I'm removing proximal contacts because my goal is to show you how to make proper proximal contacts and how to solve problems with dentin and enamel. Okay, so this is just for demonstration. So before we do silicone index, another one, because I'm going to show you tips and tricks. So since we have that kind of defects, before making any restoration, we will have to treat enamel properly. That is important. You can consider this is step 2 or step 1 actually. This is step 1 of your direct restoration. Step 2 will be silicone index. Step 1, treatment of enamel properly. Enamel has to be smooth. So we take red diamond burr. Let me magnify here. And at the very peripheral zones, enamel has to be smooth. With the red diamond burr, you can do it easily. And from the vestibular side, we can do some bevel. Bevel helps us to get good transition, color transition. So basically, bevel is dental Photoshop. Bevel helps us to make our color transition very, very smooth. So we do bevel with a red diamond. Also with the red diamond we treat proximal areas to remove sharp angles, sharp edges here. And from the palatal side we don't do any bevel, but we keep our burr straight to the perpendicular to the defect and making this enamel smooth. So this is how everything looks like before doing direct restoration. Now, as I promised you, we will go for, I will show you, I will demonstrate how to do palatal wall in case when you have patient with a trauma, half tooth is missing, for example, or I don't know, big portion of the tooth is missing. So you can do the same. You can take silicone index from the existing situation. So you have half tooth missing. You take your new silicone, mix it, and we will make impression of this defect. And then I will show you the trick. To be honest, I don't remember the author of the trick. But trick is amazing. And the author of the trick is amazing because it's so genius and simple, like crazy. So we make a roll of this silicone, same as we did for the first step of demonstration. Then we take impression from the existing situation, having our defect here involved into our silicone index, you see. And then we will cut space with a burr. Okay, I will show you step by step how to do this. We will cut this with a burr. Till silicone now is setting, I would like to share with you also some thoughts and tips related to silicone index making. You can involve dental lab for this, for example. You can take impression and send it to the dental technicians. They can do wax up and then you will take impression. From the wax up to have silicone index, why not? Very interesting and good approach. A little bit more expensive, takes time, but sometimes works. When it works, like you have patient, for example, you have patient with multiple defects, a lot of caries defects, posterior teeth, anterior teeth, everything is destroyed and you are going to do direct bonding. So you take impressions, send it to the dental technicians, that they will create the new anatomy of patient's teeth with proper occlusion. And then you can take silicone indexes for the frontal teeth, also for posterior teeth. You can create stamps, you can create special translucent silicone to make injectable procedures, to do tabletops or whatever. There are many techniques, by the way, how to transfer wax up into the patient's mouth, even for the full mouth rehab cases. When you do full mouth rehab, you raise vertical dimension of occlusion, for example, when you are treating worn teeth, okay, erosive or, I don't know, bruxism or whatever. You determine the proper jaw position, you record CR, you send all this information to the dental technicians, and then in articulator, making teeth proper, with a good anatomy, okay, and then you can transfer this into the patient's mouth like a long-term mock-up, or even you can do final restorations where every single tooth can be separate. A really good option, saves a lot of time, not expensive for the patient, really conservative because it can be done prepless for posterior teeth. So, the good option. If you are interested in that approach, for example, if you're really interested in this, we have our hands-on course, which is called Big Composite Course and Rabidam. You can come to our training center in Kiev, and we will teach you how to transfer this wax up into the patient's mouth for full mouth rehab cases, how to do single restorations like anterior and posterior teeth, how to use the Rabidam. This is the only course where you will learn direct, indirect, and semi-direct techniques utilizing composites in daily practice in restorative and prosthetic dentistry as well. If you're interested in this one, write the request in the chat where you have got your registration to this course, and our course coordinator will send you more information. Okay, so now we have our silicone index set. Let's check what happened. See here we have palatal side, and a defect. Then we take a pencil, we take our regular pencil, we draw the outline of the tooth, the outline of the tooth that we are going to restore. The outline like this, and then you take burr. The best option is to have a so-called carbide or multi-bladed burr, metal one, because it cuts silicone and creates pretty smooth surface. With a diamond burr, but again, diamond burr is not a good option. It's better to have carbide burr, as I told you. So now you have to cut silicone till these level. So you cut silicone till the level of the palatal wall. Adjacent teeth can be taken as reference. I'm doing this just to give you an idea of that approach, of that technique. And one more time, unfortunately, I forgot the name of the author. If you know the name of the author, by the way, write down under that video. Will be good to know for people the author of the technique, because technique is really amazing and very easy going and saves a lot of time, saves a lot of nerves, and gives good results. Okay, so that is the idea. I'm not precise. I don't want to spend time for this. I would like just to show you the procedure, the approach that you can then implement in your daily basis in cases with a severe defect that you have to restore. Okay, so now let's go for our restorative part. We have created our silicone index. We have treated enamel properly. Another step which is very important for bonding procedures or bonded procedures is to use Rabidam. So I'm going to apply Rabidam isolation. I will do Rabidam isolation, and then we go step by step with restorative component, restorative part. And then I will show you how to determine opacity, how to place our enamel shade, dentin shade properly. So this is what I'm going to show you step by step. And then finishing and polishing, creating lifelike shapes, forms, transitional angle lines, and many, many other aspects. So we do Rabidam isolation. That is important part because, you know, bonding effaces moisture. And also, rubberdam is pretty comfortable to work with. You are controlling process, so you are not afraid that something will get to your restorative part, like bleeding, saliva, or if you drop any instrument or matrix, it will stay in the rubberdam. Or veneer, when you bond veneer and it falls down, it's good to have it in your rubberdam, not in patient's mouth. Okay, perfect. Now let me put the frame, and then we go with restoration. So that is isolation of frontal arch. You see, it's not very difficult. In terms of time, it's also not so long. Let me do inversion. Inversion is an important thing because you have to get your rubberdam inverted, because if there is no inversion, or invagination if you want to call this procedure, because saliva can go from dead areas, and it's not a good thing to have when you do restorations. We do inversion also here. I don't like to work with floss ties when I do restorations of that kind of defects, where I will have to place my matrices, because I need space for matrices. Okay, next step. If you don't mind, I will skip etching procedure, because I'm not going to waste time for demonstration doing etching, rinsing, and so on and so on. For regular cases, definitely we have to go for a bonding protocol from A to Z. Okay, it is important to know which bonding system you use, if it is total etch or it is self etch or whatever. So you have to work with your composite according to instruction. That is important. This is how we protect adjacent teeth with no perforated matrix, for sure. It has to be non-perforated. Then you etch, then you rinse, you dry, then you apply your adhesive. I don't want etching and adhesive to be on adjacent teeth. That's why I want them to be protected. I will switch that filter. I like to work with brush when I'm using adhesive. I work with brush. I love to work with brush because the brush is very flexible and it can go really in tiny areas. Okay, then we light cure. We will light cure it. Also, you have to keep time of light curing according to extraction of your adhesive and also the lamp that you are using. That is important. After adhesive procedures, you can remove matrix and then you can go with your restorative part. In cases when we have big dentin exposure, before doing my layering procedures, I want to cover dentin with a thin layer of flow. You can use dentin shade, highly filled, or some bulk filled materials. If you use bulk filled, just keep them in dentin only. So it's like a liner. It will be an adaptive layer with a periodontal probe. We spread it in dentin area. Then we light cure it also. Okay, now we are ready for next step. The next step, enamel, right? Enamel. But before working with enamel, let me show you how do we work with a silicone index. First of all, this is what I forgot to do, by the way. Before doing etching, can we have camera on myself, please? General view. We need general view. That is important because I forgot to do something. Before you do etching and rinsing, okay, before, so you placed rubberdam, done. Then you take your silicone index and you have to understand if your silicone index fits, okay? That is important. So for sure we have to cut from the silicone index palatal extension. We don't need this palatal extension because your rubberdam will be not happy to have it. Then we cut half of K9. In our case we have isolation of K9, so we cut half of K9. and we keep our lateral incisors and centrals here, okay? So then you try in your silicone index. You try in your silicone index and it should be perfect. Then, another thing, look, that is the thing. Because as I told you, silicone index gives you enamel, palatal enamel. Palatal enamel determines the layers of dentin and vestibular enamel. So we have to understand how much enamel to place here. How to determine? That is important. So if you have a case where there is high type of opacity, okay, high opacity type, instead of enamel, here you can place body shade of your composite, body shade. That is good, body shade. There are many types of composites, by the way. This is important to understand. There are composites like two opacities, like you have just dentin and enamel. For example, like mecharium enamel, you have just a dentin and enamel, done. In this case, they have a specific enamel. They have enamel that is high value, low value enamel. High value enamel, actually it's not enamel like other composites have. It is like slightly like body, okay, slightly like body. It's a little bit opaque. That is the thing, okay. If we discuss composites that give you like opaque dentin, body, chromatic enamel, and translucent enamel. So basically you have four translucent opacities of composite: dentin, body, enamel, and translucent enamel. Four opacities. So in case when you have high opacity type, you put body shade on palatal wall, not enamel, body shade. If you have normal type of translucency, you put enamel, and if it is high type of translucency, you can put translucent enamel there, okay? If you have a high type of translucency, or you have normal type of translucency, the thickness of enamel layer is also very important. In most of the cases, statistically, it has to be about 0.5 millimeters. How to determine that? Look, you can take your silicone index, you can take your periodontal probe, and you put your periodontal probe on the floor of your silicone index. From the floor to the end of incisal edge, you can see the height of your silicone. In my case, it is about 1 millimeter, okay? But I want to have it 0.5. So what I will do, I will take scalpel blade and I will cut my silicone this way. Let me zoom out so you'll be able to see from where. This way, okay? This way. So I will decrease the height of the silicone index. Be careful. Okay, so we can now measure 0.5. This is what I want to obtain. And we have also very sharp outline here that will be easy to work with composite. So this is how we can determine our composite layer, enamel layer here. Now I will take my enamel. I will take chromatic enamel, will be A1. In our case we have A1, by the way. So we use A1 enamel, A2 dentin. By the way, before placement of enamel, what we have to do, actually we do it before bonding. Again, we try in our silicone index, we cut our silicone index, we make this line here with a sharp probe. So now I know how much enamel I need to place, and then we do etching, rinsing, and bonding of the tooth. Okay, that is important in order not to contaminate your bonded portion. So we do it before, etching, rinsing, and bonding. Now I'm taking my enamel, chromatic enamel here, because I'm going to do normal type of translucency, and I place my chromatic A1 enamel. spread it. Sometimes, by the way, it's not easy to manipulate with composite over silicone index. The reason why is that you can have some oil, silicone oil here. To make life easier, what we can do, we can take ethanol or alcohol and wipe our silicone before placement of composite. This is what we can do. Okay, with ethanol. So ethanol will eliminate this oil area, silicone oil. We go with enamel towards incisal edge, so it will be cut off because of the silicone itself. And see, it has now the same level. The composite has the same level as my cutted silicone. This is the key point of this step. The key point of this step. Also, you can use brush, dry brush. We use dry brush if you want to make your enamel more smooth. And then we are going to do our restoration. We will restore palatal wall. Before I will take this here out from the silicone. Okay, good. So we have now our enamel here. So what I do, I bring my silicone index with palatal enamel into the tooth. Now the tooth is edged, rinsed, bonded, and it is ready to accept enamel. We go, we press, and now the problem. The problem is that I don't know exactly if I have good adaptation of my enamel and the tooth. What I do first, I take brush and I try with a brush to make adaptation here with a brush. Okay, and another thing that I prefer to do is I'm taking a very small portion of dentin, a really small portion of dentin I will take, and I will put this small portion of dentin in the base of our silicone index, and without forces, just gentle push of dentin towards enamel. So my dentin now is very good adapted to the tooth surface. Okay, and also we have good adaptation of dentin to enamel zone, to enamel, palatal enamel. Okay, so now we are happy to continue. Before light curing, take thin instrument and check if you have space here between teeth, because sometimes if you place too much enamel, you will have no space to put your matrix later on to restore interproximal contact. So be careful, take thin instrument. You can use scalpel blade or this instrument. This one is very, I think this is thinnest instrument in market that you may find. This is from Hufridi. Let me show you the name. It's Acroflex, you see? Nice one. Okay, so after good adaptation, we can light cure. So the dentin portion is a good tip, because sometimes you place enamel in your silicone index, you light cure it, and then you take your silicone index out and you have small space between enamel and the tooth, or the palatal wall may be broken. So in our case, the outline is good. So I can go straight with interproximal contact restoration. I will take matrix. Sectional matrix is a very good option for proximal contacts. Very good option. So we put them into vertical mode. Vertical, be careful, don't push, don't force. because you know if you force you may break your palatal enamel, so we have to be very, very gentle with this. We bring it into sulcus here, all the way into the sulcus. Then we can use wedge. We can use wooden wedge or rubber, or plastic wedge, is up to you, to make a good adaptation of matrix in cervical area. I'm keeping my matrix from palatal side and not letting not letting the wedge to force my matrix palatally, so I'm holding my matrix from the palatal side. Okay, that's it. What I want you to see is that the matrix, the sectional matrix, is it gives you a very good proximal contour, very good proximal contour. If you want to make it more rounded, you can push it here with your finger. If you want to make it more straight, you push it from here, you see? So you can play with the matrix and your composite. So now I will take my enamel, I will take my chromatic enamel, A1, because I have my normal translucency type. Basically, if you work with high opacity type, so what you will have to do is you will have to work with body shade. With a normal translucency type, we work with chromatic enamel. If you work with high translucency type, you can work with translucent enamel. So first we do adaptation. We pack our composite with instrument. We would like to have good adaptation between layers of composite and also between composite and the tooth. That aspect is also important because it gives you the box, the level for dentin. So we have to be careful about the profile. So how do we check profile? We turn head of our patient to side. And now we can see profile. This is our reference point, so we place our flat plastic instrument to get a good level of the reference. So it is here. Okay, and then it has to go down progressively. So it goes down progressively. Okay, to make it smooth, you can use also brush. And the thickness of this layer, the thickness of this enamel, also in general has to be about 0.5 millimeters. 0.5, okay? So we go with our thin instrument. We bring our thin instrument here to make good adaptation of composite to the cervical portion of the tooth. And here let me show you the trick before light curing and before checking the profile. You take your finger and you press your matrix forward, so composite will go slightly to palatal side and you will have better adaptation of your composite. Okay, now what? Now everything looks not bad, making more rounded distal corner. Here you can see some overhang, so it can be fixed with flat plastic instrument before you will light cure. So what I will do, I'm taking my flat plastic instrument and I'm pressing here. Okay, to have good adaptation of my matrix here in the cervical area. Let me bring my microscope more down. Yeah, here. And we light cure. Okay, perfect. So now we can take our matrix out. we can take our matrix out. I need tweezers. I think there are no. Okay, let me take my fingers instead of tweezers. We take matrix out. We take also wedge out. Okay, and now we will do mesial contact. Mesial contact is more difficult, by the way, than distal. Distal contact is created by the matrix itself, but mesial is more straight, so you will have to manipulate with the matrix. You will have to turn your matrix to push your matrix towards adjacent tools, so you have to make this manipulation, and you will have to work with your both hands, and your assistant will have to help you with light cure. Okay, now let me stabilize my matrix with a wedge here. Okay, it's done. And now the same thing, I will take my chromatic enamel in low translucency type will be body shade. In high translucency type can be translucent enamel with a thickness about 0.5 or 0.3 millimeters. This is what we have to do in high translucency type with a translucent enamel. See, I'm not giving you brands of composite because they are different, but the principle is the same. So you can use any brand of composite. The only thing that you have to know is the opacity type of your composite. The one that I'm using here, exactly, this is Filtech Ultimate. So this is A1 enamel, enamel A1, which is pretty simple. A1, enamel, done. Turn the head to the right, so now we can see the profile. We have to work with profile properly because, again, it creates height of the box, and it will be used for determination of dentin layer later on. Let us make an adaptation here. Let us make adaptation. Then we go with a profile. We bring the composite down. We bring composite more down. Now we can put our matrix forward. Here we have more straight contact area and corner brush to get a little bit better adaptation and to make it more smooth. Okay, next. What will be the next? The next will go with straight view. We'll have to see the straight view because I want to see how the corner looks like. Maybe I will need to manipulate with my matrix. I have to. See, there is no contact here. So we have to move. You see what happens? That is the thing. That is very interesting and important thing to take this into consideration. There are a lot of small details that we have to take into consideration. Light cure, but before light curing we have to press. I don't have third hand, unfortunately, in cervical area. We'll have to press here, or maybe I will do it this way. Here. Anyways, we need third hand for this, but the principle, you have to know the principle. So you turn the matrix and also you press with flat plastic instrument in cervical area, so that will help you to avoid overhang. Perfect. We have now enamel shell or proximal box. You can call it as you wish. Remove our wedge. Now we're ready for dentin. Okay, the most interesting thing, because that will give you success of your restoration. So let's take a pretty big piece of dentin. This is A2 dentin. When we discuss translucency types, okay, or opacity types, it's easy to understand vertical component of dentin layer. In other words, it is easy to know how far to go with dentin towards incisal edge. This is easy, really. So first, good adaptation of material. We have to make a very, very, very good adaptation. This is the first thing that I do, adaptation, to avoid voids, bubbles, and to get good integration. So we press, making massage. Then look what I do. I get my dentin layer over the half, or a little bit less than half of our bevel, enamel bevel. So literally I put some very super thin layer of dentin over enamel bevel. Okay, now we have to work with palatal vestibular component of the dentin, which is crucial point to get success. So first of all, I want to see where is the end of my natural tooth and where is the defect. So I'm taking periodontal probe and I want to create a line here which is 0.5 millimeter depth. The depth of the line is 0.5. So that is the level. That is the level of the dentin that has to be in cervical area. And then I take my flat plastic instrument and push the rest of portion to get the same level. And now I move it down, 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 and I remove excess of composite. So it becomes thinner here, and it is thick in the cervical area. Then afterwards, what I will do, I will keep space for enamel in incisal edge, 1.5 millimeters for normal translucency type. Okay, also when we work with dentin, it goes straight from the cervical area, so there is a vertical dentin zone. See what I'm doing? And now I will take my dentin back to the beginning of the chamfer. I'm moving dentin now to the cervical zone, covering the beginning of the bevel. That's it. Okay, next. What I will do next, I still don't know if I have placed dentin enough. To the incisal edge it is easy, but it is difficult to understand from palatal side to the buccal side. And there is a trick that is called trans-illumination test. Trans-illumination test, let me explain you how we provide trans-illumination test clinically. This is what we do without microscope. So we move, can we have the general view? So I will show you to my colleagues what we do. We move microscope forward, and then I place my mirror here as far as I can see. From the microscope, you can see the light here in my chest. No, we have to have the general view. Okay, general view. It's the light here. So what I want to do now, I want to reflect the light from the microscope, not to myself, but to the incisal edge. So the light will highlight the palatal side. Okay, palatal side. Yeah, you can see now here from that view. You see? Again. Yeah, see what happens? So now I will do it with microscope, but again, in patient's case without microscope, I have to see what happens. So the trans-illumination test, look what happens with the trans-illumination test. You see? The light goes through palatal side. So what I want to see, I want to see very smooth transition from natural part of the tooth to my restorative. There shouldn't be any gray zone or white zone or dark zone. If you see too much translucency when you do this transillumination test, and you can see everything is translucent like enamel here. See, it's very bright, very transparent actually. That means that there is not enough dentin. But in this case, in the incisal edge, we don't need to have dentin. But if you will have the same thing here in the middle, for example, is too much light in the middle, that means there is not enough dentin. If you have dark zone, actually dark zone, the dark zone means that too much dentin. So this is a transillumination test that is very helpful to understand the palatal buccal component of your dentin. Now we will split these things to create mamelons. We will create classic three mamelons. The distance between mamelons has to be different also. We can make them more rounded. Free more space here. Okay, then we will push some of the tips a little bit more down. You can go even to incisal edge. That will create more natural looking thing. Okay, so you can play with these mamelons. You have to check how these mamelons look like on the adjacent tooth and try to mimic it. Okay? Also, the angulation of mamelons, they have to go a little bit more to mesial side, like this. So in my case, the distal mamelon is straight. I don't want to make it that way, so I want to angulate it, incline, more mesial, like this. It's better. Then I will light cure. This is another transillumination test, by the way. Look, in the middle, the camera doesn't show you the same thing. In the camera, by the way, there is a black zone in the middle. In the camera, black zone. See? Black zone. It's bad. In my case, when I see through the microscope, I cannot see the same. The camera shows this. I don't know why. Okay, so next, if you want to do any characterization now, for example, you want the tips of mamelons to be more chromatic, you can use dentin, like A3 or A4. There are flowable dentin, highly filled flowable dentins. The one that I really like to work with is Inspiro. This composite from, you see the web page here, by the way. This is the one from Didier Dici, Inspiro. Body I5, it is dentin 5, like A5. It is highly filled flowable, so you can make tips of mamelons more chromatic, natural looking. Also, you can put some very small tips towards incisal edge that will give you some also nice natural looking things. If you want to highlight mamelons, you can put between mamelons translucent enamel. This is actually what I do. If I want to highlight my mamelons, what I will do, I will take my translucent enamel, CT, translucent enamel. This is what I will do. I will take my translucent enamel and I will put this translucent enamel straight between all of these mamelons. For the tooth that is high translucency type, you have to do this. Okay, so we push. We don't want to have voids or bubbles, so we have pretty big portion of this And composite, it is pretty soft composite, by the way. But anyways, we push it, push it, push it, push it, push it, push it, push it. You have to keep it straight between mamelons and to keep space for enamel, chromatic enamel. So if you have excess, just take this excess out. Okay, that's fine. What else? To make it more smooth, brush. It's a very good instrument. I use it wet, I use it dry. Okay, we light cure. If you want, guys, to do some white, zones like hypercalcification, you can do it now also with a white tint if you want. Let me check. Without orange filter, you see the chromacity. I like the mamelons are a little bit more chromatic, you see, like a natural teeth. They are like this. It can be like tooth can be A1, but the tips can be A3. Very natural looking. Okay, let's go for the final step. That will be enamel. So again, if you want to create some internal effects like a white lines, let me show you. If you want, let me take a white tint. White tint. Where is my white tint? Skin white. No, it can be like this. Like a spots of enamel, the white enamel, I mean. Then you take your thin instrument. This is maybe too much, but just you can do it before. And it is not opaque. It is not opaque enamel, because opaque will be a disaster. If you don't have good tint, like a milky white enamel, for example, what you can do is you can mix it. You can mix your opaque white tint with flowable composite, with enamel flow, like with A1 or translucent flow. You can mix it. And you will have pretty good tint for characterization. Okay, so now let me go with a final enamel layer. I will take my chromatic enamel. Chromatic enamel, this is A1 enamel. I didn't show you halo effect, by the way. Halo effect can be layered. You can layer halo effect with dentin. If you want to do halo effect, you do it with dentin shade, the same dentin as the core dentin you use. In our case, it was A2. So I can cover this small line here with dentin, but I would show you also another way, easy way. By proper finishing and polishing of enamel, optically you will get your halo effect automatically. So you can skip halo effect layering, and you will make it by optics, by proper cutting of enamel from palatal side. I like to work with these stiff composites because they keep shape. See, I can put a very big portion, actually, big portion of composite, and play as long as I want. So there is no distortion. It does not melt like some soft versions of composite. This is pretty good personal. This is actually personal preference for myself to work in such way. So first what I do is I'm spreading composite all over the surface. I'm making good adaptation with this instrument. I want all layers of composites to be well adapted and joined to each other, connected to each other properly. And then afterwards I will make it smooth with brush. During this process, during you layer, you can actually layer anatomy. You can layer transitional angle lines, you can layer so grooves, mamelons, whatever, you can do that. If you know, if you have experience, if you have good space filling, so you can have good orientation in space, I mean space orientation, so that is the technique. But you know what may happen if you have not good space orientation? What may happen, you can create some good anatomy by layering, and then after you will remove your rabidem, and during finishing and polishing you may lose everything. So try to do initial shape by layering, okay? Initial shape. This is what I want to obtain now, initial shape. But the rest will be done during finishing and polishing in very, very easy way. In very easy way. This is what I'm going to share with you straight after that step. First I will do some good adaptation, make the transitions smooth. See, I'm making some small overlap of enamel. I'm overlapping incisal edge. This is important thing, by the way. Okay, so let's say that's it. Let me light cure. Some people, when they do light cure, they do it just initially. Then we remove orange filter. We want to see if we need to add something or not. If everything is okay according to the volume, we can go with a final step. You can cover the restoration with a glycerin gel, and you can light cure through the glycerin gel to light cure oxygen inhibited layer. Or there are many other ways to remove oxygen inhibited layer. Basically, you can use ethanol. So when you do a final light cure, you take, where is my ethanol? Who knows? Okay, just we take ethanol and we wipe everything with ethanol here. So that is easy. Ethanol also removes oxygen inhibited layer. And now we go with finishing and polishing. That is another important part. Get fresh air, drink some water, because that is important to give you protocol. The protocol of layering I gave you. The very important thing was to create proper enamel thickness and also proximal enamel thickness, and to play with dentin from palatal to vestibular part. Transillumination test. Good thing. Okay, now we go for finishing and polishing. What I will do, I will take first instrument that I will take for my finishing and polishing protocol will be disc. 5,000 RPM. I'm taking disc, and with disc I would do what? I want to play with outline. First of all, I want to play with length, if the length is correct, and also I want to play with corners. See, rounded, very nice, progressive. Distal in my case, here not, so we can improve it. Can make it more rounded. Okay, now it looks better. Still not perfect, but way better. The next step, I'm going to my handpiece. I will take my handpiece and I will take a burr, and with the burr I will create surface. I will create texture. So let me check if we have texture on adjacent tooth. Yes, we do. Look, we have a very nice horizontal texture. See? So I want to have the same texture here. If there is no texture, you will use red diamond burr, or you will use yellow, or you will use carbide. If you want to have moderate texture, you can use medium grit burr. So now I'm taking my medium grit burr. The speed will be about 40,000 RPM, no water, but with air spray from assistant side. Without any pressure, I will move my burr along the tooth surface, the restoration surface, sorry, to make it matte. See, when I'm working this way, in that area I have small bright zone. That means there is a small depression, and I want to make everything consistent and uniform. Matte. You can remove some overhangs also, especially this one. This one can be taken with a scalpel blade, by the way, easy. So we make everything uniform here. And you can see texture. Let me remove the light. Yeah, I think this is better. So you can see texture. Right. Now, we will work with planes. I take a look at the adjacent tooth. Cervical plane. It is bulky. Then flat surface, which is middle plane. So we have to find where is the transition between cervical and middle plane. Middle plane ends where incisal plane starts, with a slight palatal angulation. So here is it. And I want to do the same on the tooth that I restored. Now, with the same burr, I will start working with angulation of the burr. I will angulate the burr. And if during layering procedures I was not attentive to that component during layering, I will have to apply some force. So basically I have to incline, to angulate that part more palatally. Assistant helps you with the air spray, or you can do it with a water. Now, straight zone and cervical. I did not restore cervical part, but if, for example, I would if I would do direct veneer, so that is the angle of the burr highlighting cervical zone. So, perfect. Now, what I will do now we will work with the transitional angle lines, which is very important thing. So, just take your pencil to the peripheral aspect of adjacent tooth and bring it this way, just up and down. It will create by itself. See? So, I'm not drawing anything. I'm just following the bulbosity of proximal zone. Now, I'm holding the pencil with the left hand, even just moving along the proximal zone. So here, I want to have the same here. I want the distance between transitional angle lines, distance from here to here to here, similar to the adjacent tooth. And we can play now clever with that lines, because playing clever with transitional angle lines, you can make tooth slimmer or wider. Slimmer or wider. Slimmer or wider. What does that mean? If I want tooth to be slimmer, what I will do? I will make my lines more into the center, and everything that is a part of the line has to be beveled. So what I have to do now, I will have to bevel slightly that zone. with the same burr. So I'm not touching lines, I'm going here and making beveling. If you don't want to touch adjacent tooth, you can protect adjacent tooth with metal band, like this. So we go to very proximal peripheral aspect, beveling that transition. The same will be done here. So if you want to make tooth slimmer, you go with these lines more to the center. If you want to make this tooth wider, you go more to the peripheral aspect. Okay, the next we will take disc. Now I will do the same with disc, 5000 RPM. And let me show you one small trick, because you know it's good to have very rounded transition to proximal, so we can take a flat plastic instrument and deattach the tooth slightly. A little bit painful procedure, by the way, to the patient, so you have to warn your patient before doing this. I don't want to lose interproximal contact, so I'm not going to proximal contact zone. I want to make this transition smooth. Now I can remove this line also, just not to have it. Same from easel part. Make some deattachment. Let's remove pencil drawings. And if you want to make this texture less visible, you can play a little bit with the disc over the surface here. Now, regarding the halo effect and these notches, we can play a bit with the incisal edge. Let's take mirror and this overhands. Again, I was working with one hand, so with the two hands will be easier. You can cut them easy with a scalpel bit, you see. Scalpel bit is easy instrument to take the excess of composite out, or with a thin diamond burr. Okay, it's easy. If your silicone index was good, you don't need to have any occlusal adjustments. Just polish it with a rubber. So that's easy. And now I want, look at this one. It has a slight palatal bevel on incisal edge, and I want to do the same here. You can use disc for that. You can use disc, or you can do it with a burr. There is some overhang, so we take this overhang with a disc. Okay. And then we will improve this with a special rubber, with a rounded rubber later on. But this is the small beveling of the incisal edge at the beginning. Okay, so now after that step, we go with our vertical component of finishing and polishing. By the way, the only thing that I don't like before that step is this overhang that I can take out with a scalpel blade also. Yeah, now it's better. A little bit more. Scalpel 12D, very good instrument. Very, very good instrument for that. Okay, vertical component. Let me check on this one. Here we have our grooves. And I would do now the same here. The tapers. What I will do first, let me simulate notches here at the base of the groove. You can do it with a disc or with a burr. And then I'm taking the rubber, the tape, the rubber point. Let me show you the one that I'm using. Very good one. This is the old rubber from Dentsply, enhanced. You see the shape. It's very good. So you can go with this instrument down 5,000 or 7,000 RPM with slight pressure with water. I will be doing this without water. Because why with water? Because when you press, it generates heat. So first, I will go down, and as much I press, as deep I make the groove. So the depth can be controlled by your pressure. First, we do vertical movements. Vertical first with water, because we press. Vertical, you go up and down, then you create wider base of your tapers. So we go here, up and down, and then to the side, up and down and to the side, up and down and to the side. So the base has to be wider than the tip. And you see that it becomes very sharp in the peripheral aspects of the groove. So after that, you continue working with this rubber and making the horizontal movements. With the horizontal movements, you make the grooves more sophisticated, more rounded, more smooth. And then you can improve some polishing with the same rubber. See, now you can see the texture, the small texture that is visible, the small texture. Okay, now with the same instrument from the palatal side we have to polish. This is a good instrument. Again, if you press it cuts, so if you have any overhang, easy to take it out. Perfect. Let me check from the vestibular side. Everything looks not bad. Maybe to make this corner a little bit rounded. Not bad, actually, not bad. Now we have to do our final glaze, final polishing. What kind of instruments we can use? There are many of them. The ones that I start to use recently, they are from Jota or Eve, you know, the red one, spiral from Eve, E-V-A, Eve. About 7,000–10,000 RPM, also can be used with water. So the red one is for pre-polishing. See? Adjacent tooth also. So the red is pre-polishing, but now even with this pre-polishing instrument, you see that composite becomes shiny. And there is the high polishing one, white. So that one makes magic. With water, because it generates heat in the speed of 10,000 RPM. It generates heat, but look, few movements, and you can do selfie with through this tooth. This composite is good polishing one. Okay, so we create nice polishing with that two spirals. See how it looks like. Another thing that is very important is to have a good integration in cervical area. So I'm using very thin strips from 3M, and with the strips, if I have any overhang, I'm just making polishing process in the cervical aspects of the restorations, because I want to have good and healthy gums around my restoration. This is non-abrasive part. I will clean adjacent tooth with non-abrasive part. Okay, so that is the good thing to have. So that's it. Our you see the texture, by the way. You can see texture that was created by the blue burr or medium grit burr. Okay, so that is texture that comes from medium grit burr. We have the transitional angle lines. We have vertical component, halo effect, slightly opaque incisal edge, you see. And the protocol is pretty simple. The author of the protocol, the protocol comes to us from can we have a general view? Yeah, from dental technicians. It comes from dental lab. One of the first that I learned from is Daniele Rondoni, dental technician from Italy. Then was John Di Manauta. There are some modifications of the protocol, but you see it's very easy. The most important part that you have to understand regarding the shape is palatal wall. When you do palatal wall and then proximal, actually you determine the future shape of the tooth. And then the rest is done automatically with corners, with planes, with transitional angle lines, and with the vertical component of the restoration. Okay, what else? Again, if you are interested to learn all these steps, by your hands under my supervision, as well as indirect restorations, full mouth rehabs, posterior teeth, and rabidem. Come to our module, actually, that is dedicated to composite, big composite course, the name of the course, big composite course and rabidem. It is just for 7 people, 2 days, hands-on in Kiev. I will be more than happy to see you. Then that's it. Let's do Q&A. I will answer your questions after 10 minutes break. So see you in 10 minutes. Let's go for Q&A. You feel live? Okay, we're back. Thanks everybody for watching us. Now it's time for a Q&A session, and it was pretty intensive, I think, with that practical tips and tricks, and I hope that you will find out something very important and useful to be even better than you are now. I know that you are best ones in dentistry, but there is always the way for perfection. So, questions. I will start from the bottom, and the thing is that some people they were complaining that video is not playing like 3 days ago, because live, oh, I'm out of battery. Live broadcast is right now, so the video was not playing because of that. Another question is Dylan. Hello, Maxim, great presentation. Hello, Dylan, thanks for your kind feedback. The question is, when you make a mistake during the procedure of direct composite and you have to remove part of what you have done, what are the steps to repair? Good question. So if you need to do some adjustments or repairment of your composite, if you're doing it right now, which means your composite is still fresh, your monomers in composite are still fresh. What you can do, you can make some roughening with a burr. For this you can use a blue stripe burr or medium grit burrs, or you can do some sandblasting just to make the surface even more rough. Then you can apply unfilled resin, okay? Unfilled resin, or if you are working with a bonding systems like a fourth generation, where you can find a separate primer and separate adhesive, you can use adhesive. Okay, so you do sandblasting or roughening with a burr. You just dry everything, dry. Then you take your unfilled resin, cover your restoration, dry again, dry thoroughly, then you light cure, and then you can continue repairing the fragment of your composite. Your composite will have still bonding, chemical bonding, because monomers are still fresh, and there will be some micro retention after roughening with a blue burr or with a sandblaster. Honestly speaking, for that step, when you have your fresh composite, you can skip sandblaster. So you can just make roughening with a burr, and then you can go with your unfilled resin, dry, light cure, and then you go. But if you have your old composite, for example, you have your patient came after a week or 2 days or a month, doesn't matter, and you need to make some correction. And if you will go into composite without touching patient's tooth, you want to repair your composite, in that case you create some bevel, then you go with sandblaster. In that step it is important to get some micromechanical retention, and then you can use a composite primer. The one from GC, for example, they have composite primer, and then you can go with your adhesive, and then you go with your composite resin. So that are the steps. Okay, next question. Cannot hear anything. Now you can. Okay, Mohammed Ibrahim, can we add small layer flowable when building proximal wall? Mohammed Ibrahim, first of all, good evening or good day. I don't know what is your time zone. Thanks for watching us, and it's just to be polite, okay? And then I can answer your question. If you do proximal area, I'm not a big fan of flowable composites, the regular ones, because they can make some weakening in your strong composite area. So I prefer packable for wall restoration. I prefer packable composite. Konstantin Konstantinov. Hello, Konstantin. Would you share your composite instruments kit? No problem at all. I can show you exactly which ones I was using. Now I will switch into my frontal camera. You can see me here. Okay, so the one that I showed you, it is Acroflex from Hufridi. This is very good instrument, very thin, one of the thinnest instruments in the market. You can see it is nickel titanium. Yeah, on my face it will be visible, you see. Nickel titanium, very flexible, good for interproximal restorations. This is what I like. Then we have this Packer. It is also from Hufridi, but actually you can find similar from different other companies like LM Art, the one from Style Italiano, very good one. I also like to work with Condensa, gray instrument. Then the thin Fissura, the green one, and then Modella, the blue instrument. This is some kind of Fissura from Hufridi. I like to work with these instruments because they are black, and when I'm working with microscope, there are not too many light reflections. So this is what I was working with, and this one is also Hufridi, black instruments, less light reflections. Okay, but again, the ones from Style Italiano are very good instruments. I love that to work with them also. And we have also our Ukrainian brand, which is very good in terms of quality and very cheap, comparable to that brands. But I don't know if this Ukrainian brand is available for foreign countries. Okay, next, Robert Green, my friend. You are always with us. Last time, I think, when we were doing an endodontic session, your friend was with us under your name. Anyways, nice to meet you again, and good evening. Thank you for the useful video. I thought I know a lot about this topic, and there was a lot of new tips and tricks. This is what I'm very happy about, to give you some tips and tricks even for high-level dentists that know many things about the topic of our online meeting. So that makes a lot for me. That means a lot for me. May I ask, what type of composite system would you recommend for the natural layering technique? Actually, I work with a Filtech Ultimate dentin and enamel, the one that was specifically designed for natural layering technique is composite from Didier Dici. The name of composite is Inspiro, very good composite, super composite. With Filtech Supreme, the enamel colors are coned and chromatic enamel. What is coned? I don't know. Coned. Actually, enamel of Filtech is chromatic. You can find chromatic enamel. Like I use A1, for example. There are A2, A3, and so on. Could you please discuss a bit more how to make and use for opacity the individual color guide for Filtech? You can create, you can buy a product from Smile Line. This is the name. You can Google it, Smile Line. Okay, Smile Line. It is a company from Switzerland, and they do products for dental technicians and for dentists, and they have special kit for you to do your customized shade guides with the different composite systems that you are using. So you can buy that one, read instruction, and you will be able to do this customized or individual shade guides for your composite systems. Then could you always use water spray for finishing and polishing? Not always. More often I'm using air and water spray from assistant side. So I work dry without any pressure, low speed. Assistant dries with air and sprays with water upon my request. What is your protocol if you make a mistake and have to drill back some composite? You just bond it again after drilling. Yeah, that was a question that I replied. So, but just to recap, you rough the surface of composite with medium grit burr, you dry everything, then you apply your unfilled resin, dry, let cure, and then you go. This is the way. But if you touch the tooth Okay, this is what we are discussing about composites. But if you touch patient's tooth, then you have to repeat bonding. You have to etch enamel, you have to etch dentin if you expose dentin and you touch dentin with a burr. So you have to go for the bonding protocol. But if you just go into composite without patient's tooth involvement, you don't need to etch, you don't need to prime, you just rough, then you go with your unfilled resin, dry, light cure, and then you go. Okay, prot. Hi doctor, what kind of burr was used for contouring? Hi prot. I was using just a regular taper medium grit burr. It is not a very special one. Any burr you can use, like flame burr. Take the flame shape, medium grit, and you are fine. I used the one from my veneer kit preparation for veneers. I just took this one and I worked it. When Mohamed Ibrahim, when make a transition with disc, there will be a risk to open the contact. How to do it in an expert hand? Mohamed, hello once again. I will be how to say, I will, oh my God, I forgot the word. Anyways, so if you were very attentive, I did not insert disc in very proximal area. I was working in transition, touching very gently interproximal embrasure. In that way, you will never ever open interproximal contact if your interproximal contact is thick and strong. Okay, use soft discs, don't use coarse discs, and everything will be all right. Oh, now, hi Maxim. Okay, nice. It's nice to say hello to each other, to be honest, because since we are online, but still we are human, and you know the normal, regular conversation, polite conversation is very important. Nowadays, specifically because of that quarantines and restrictions, that we were not able to communicate with each other in life. So still we need to have this, you know, human touch. Anyways, Maxim, GE name of burr used for making the depression. The burr name was, it's not a burr, it is rubber point. Let me Google it, I will show you. Enhance. Rubber point dent sply. Okay, enhance rubber point by dent sply. These ones. Enhance finishing points. This is what I was using exactly. Enhance rubber point. This one. It's nothing really special. You can find them everywhere. What are steps of repairing breakage of meso-incisal angle? I have had a patient. Who break the meso-incisal angle eating nuts. Do you recommend to repair on only the part? You can repair. Actually, you can repair. If your restoration is well integrated with good bonding, with good protocols, you can make bevel in your composite, extra bevel, then you do sandblasting, then you take your composite primer, and then you go with your repairing procedures. So that is the way. Dr. Dimitrov, if we have class 3, when we decide to make the whole veneer or just class 3 defect, try to do class 3 as class 3. So if you have both sides, a huge A3, let's say, so in that case you have to cover vestibular surface. But if you have just class 3, keep it as class 3. Saif, how do you disinfect your brush? How do you disinfect your brush? You can use a special how to say, like, bacillol, or the very strong antiseptic that you are using to clean your handpieces and surfaces, or ethanol. Actually, the high concentration of ethanol, 96%. You can buy the very cheap ones from nail masters, and you can use them as a single use. But actually, ethanol, high concentration, can be utilized. How to avoid white lines along the junction between natural and restored surface? That is a good question, because the problem with the white lines have multiple reasons and multiple solutions. So, one of the reasons is that if you were treating enamel non-properly, which means your enamel is rough with their sharp angles, in such a case, during light curing of composite, there is a stress and slight shrinkage. So you can, in area of sharp zones, there is a very high level of concentration of stress during polymerization. So your composite can be detached, micro detachment from that area, that can be polished later on, but not always it may work. And another thing is, if your enamel was very thin in such a zones, during light curing, during polymerization, composite may even break enamel underneath. So that will be internal white line. Another reason why white line may happen is that a poor adaptation of composite. So you place your composite along the bevel and enamel. If you will just pack it gently with a brush or with a micro brush, or just put it and that's it, it may have afterwards white line because you didn't force your composite to stick to the surface. That is the very important step. So what you have to do, you place your composite, and then you have to spread your composite like you are spreading butter over your bread. Okay, so the same way you have to spread your composite very, very intensively in that area, and then you take your brush, make everything smooth, and then it works. So that is the way. And Dr. Dimitrov, if we have some bubbles after final layer, what we can use to remove them properly? These bubbles are annoying. They are crazy. Sometimes you can use these bubbles just after final polishing steps. So in that case, if you have these stupid bubbles, what you can do is you can take a very small burr, low speed. You just make the bubbles, the area a little bit wider. Then you use your unfilled resin, cover, dry thoroughly, light cure, and then you can repair these bubbles with flowable composite, the same shade as your enamel, or with your enamel shade, and then you do your polishing again. So that is how it works. Okay, next, how to disinfect your brush. Salam. The question from Salam: no polish paste, no glycerin. Hello, Salam. Salam alaikum, actually. Kif halak, my friend. So no polishing paste, no glycerin. You can skip with these high end polishing wheels that I showed you. If you can skip paste, because you saw everything by your eyes. There was no paste. And regarding glycerin, you can use glycerin after. Once you light cured your final layer of composite and you decided that you don't need to add anything, you can cover everything with the glycerin and light cure through. Or you can use ethanol to remove oxygen inhibited layer, as I showed you today, just in front of your eyes. Okay, next. If the adjacent tooth color is like from cervical A3 and from the second mid A2, can we use two shades, each one in each mid? If yes, when we do that, indenting layer or enamel layer? My friends, with these natural layering procedures, everything becomes very simple. So if you decide that the dentin is A3, your dentin will be A3 or even A3.5. This dentin of composite you will be using. And since enamel is thin in cervical area, your cervical area will be still more chromatic in such a case. And then your dentin will go thinner towards incisal edge and your enamel will get thicker. So what I'm trying to say, don't need to use different shades of dentin, you use just one. And no need to use different shades of enamel, use just one. But playing with the thickness of enamel and dentin in certain areas, you will create natural looking effect. That is why it is called natural layering procedure or approach. Next, Konstantinov, these twists, Eva twists are wonderful since I found them. Yeah, exactly. No paste, yes, good. Arshad, hi Maxim, hi. Arshad, very helpful and nicely and simply explained. Thanks a lot. Why don't you do bevel on palatal side? What are your favorite hand instrument for composite restoration? Thanks a lot. You don't need bevel because it's difficult to make a very proper adaptation there. And also enamel prisms from palatal side, they are vertical. So you don't need them to bevel. Just keep them vertical and that's it. Composites I showed you just a few minutes ago. Sorry, instruments I showed you a few minutes ago. Very sorry, Maxim, didn't mean lost sequence of questions cause of connection. Okay, you can recap because you'll have recording 14 days, Mohammed, so don't worry. Ramona, hi, very interesting course. Hi Ramona, thanks for your feedback. What type of composite do you use? What's their name? I work with Filtech Ultimate, exactly what I was using today. Also, I like to work with dense ply material, which is called Ceramics Sphere Tech, which is single layer, single shade. Mainly for posterior teeth I'm using them, or for teeth that are high type of opacity. This is what I'm using. Sarvar Manopov, hi Maxim, writing from Zambia. Wow, nice. Hello from Ukraine. Great presentation, thank you very much. What can be done if during your polishing process you mistakenly remove excessive amount of material and it changes the shape of the mesial or distal angle compared to the neighboring tooth? Can we re-etch and ends up material, or is there a certain amount of material that needs to be removed to color much ideally? Yeah, for incisal edge, to make it ideal, you know what I would do? I will make some cutback, so I will remove some incisal edge, make bevel, and if I'm working still in composite, I just do it with a blue bore, unfilled resin, dry, and then we go with your normal procedures, simply like I explained a few minutes ago. But in incisal areas, I prefer to cover incisal edge from lingual slightly to palatal, just a piece of composite to go like this, okay, and bevel from vestibular. Robert Green, thank you for the answers. Could you please tell us the name of the Ukrainian composite instruments? Maybe I will try to order them and try them. Who doesn't love good prices and good quality instruments? Let me check. I think I will give you Medin's. They have web page. Definitely here is the web page. These are a web page, medins.com. They are in Ukrainian, but I think that you may translate with the, yeah, there are no English version. But anyways, you can write them. You can write them email, or you can find them in Instagram or in Facebook. So you may write down the question regarding catalog. Maybe they are working on the English version, I think so. And then you buy them because they have very nice instruments. Basically, they have very, very nice instruments, and quality are amazing, and handles are amazing, materials are really good. Where is my translation? My broadcast? No. Yeah, here. Okay. Salam. What about blocker and omnichroma from Takuyama? I tried omnichroma for posterior teeth. Shade matching was pretty good, but I don't like the material because of handling. It is very soft for myself. I don't like to work with a very soft materials. I want them to keep shade, but it is my preference and my personal point of view. TU, thank you for presentation, Dr. Maxim. Thank you for your kind feedback. I missed the first 35-40 minutes, so maybe you have already answered some of the questions that follow. Okay, if I answer them during live broadcast, I will say that check your recording and you will watch everything. So after making some layering and you recognize that you have to remove some composite after that, do you use again the whole edge bond protocol or just clean the surface with some modeling liquid? I replied this question many times. So if you remove the burr, then you dry, then modeling resin, dry, ligature, and then you go. You don't need to edge if you work in composite. What is the instrument name of flat one what you were creating at the proximal box? I showed you just in the Q&A session, so you'll be able to see that. How powerful has to be the light for successfully apply the transillumination test when using loop light? It has to be pretty powerful. I cannot give you exactly the parameters, but it has to be powerful with orange filter because you will light Courier composite through. So be careful. Use orange filter to check this transillumination test, to make the transillumination test. What loop light you recommend more, brighter one or orange filter? Orange filter. Orange filter. You have to. Otherwise, your composite may start polymerizing. That is not very good. How do you select the enamel and dentin colors? What is your protocol with photos? Or, yeah, this is what I was explaining. I just do quick shade matching with a Vita Classic, and then I use more chromatic dentin and more brighter enamel. So this was the thing. After making the restoration and you see bigger color difference than expected, did you that automatically means wrong color selection? And if so, how to treat in case of more opaque or dark restoration? It means darker selected dentin, right? And no, if you have restoration darker, it means gray. Let's say gray. If it's gray, it is more enamel than necessary. So you have to drill it out, put more dentin, and then you bring enamel. If you have it more yellow or white, it means you placed too much dentin, so you have to take this dentin away and create a little bit more space for enamel. This is the thing. How to know if the enamel is more translucent or chromatic without trying it before purchasing it? Look, everything that is named as A1, A2, or B1, or B2, etc., it is chromatic enamel. Achromatic enamel is like TE, translucent enamel, or CE, clear enamel, or from different brands it is called by different, but the principle is the same. You can buy composites in the Compules, by the way, in small doses, so you can try them in extracted tooth or in your model if you want. Which is the chromatic, and which is the translucent enamel in Filtech Ultimate Composite. So everything that is named A1, A2, it's a chromatic, and achromatic, as I told you, is CE, clear enamel, CE, or CT, clear translucent. That is achromatic. Do you intentionally position the last enamel layer beyond the bevel level also of the healthy tooth structure not involved in the bevel. Exactly. Yeah, got it. So while my last enamel layer, I cover bevel, and also I cover slide of intact enamel. So when you etch and bond, you have to etch and bond further margins for about 2 millimeters, always. Good questions, by the way, to you. Good questions. Yesterday we provided the same program for Russian-speaking colleagues. We didn't have that much questions, to be honest, but it's good. It's good. Khalil Ibrahim, thank you for the great content and hints to the next online course. Thanks, Khalil. Thanks for your feedback. San, hi doctor, what paste material you used while doing the silicone for the index? I used just the lab silicone, which was Zeta Labor, but anyways, you can use any silicone you want. There is nothing really special, to be honest. Robert Green may ask, when you do sandblasting, what kind of sand and pressure do you use? Do you just use the same powder and machine you use after scaling? No, we use Rondo Flex. So actually, there is a machine for aluminum oxide. This is what we use, aluminum oxide, okay? Aluminum oxide is different that you are using in prophylaxis or in hygiene. So machine for aluminum oxide is different. This is what I'm using. I'm using 27 microns of aluminum oxide with water, so with the same pressure as your turbine. TU, what is the Matrix brand that you used during the demo? It's a really simple sectional matrix. It was Ukrainian brand, but you may find the same from Dentsply, from I think they are available from Garrison. You may find them from Polydentia. It's not very expensive products. So these are, yeah, Polydentia. I think this is the good choice because the quality and price is very reasonable. This is what you can go for. Sarvar, hi Maxim, is there a way in any way to adjust slight graying after finishing the whole restoration process, or does the whole process have to be redone? Writing from Zambia. So first of all, my friends, this is what I didn't mention, by the way, but it is important. Once you finish your restorations, your restorative part will be grayer, more gray than the rest of teeth because of the rubidium, because of the dehydratation. So adjacent teeth, or even the part of the natural tooth that you are restoring, will be always more opaque. It's okay. It's okay because of the dehydratation. So what you will have to do, you will have to wait at least 2 weeks. You can do checkup after, but you have also, this is also important, you have to tell this to your patient before you start restoration. You may say to your patient that after we finish, my restorations will be a little bit grayish. It is normal, and after a while, after a few days, the color will go back, and after a few weeks, everything will be very good. If not, we will have to make some correction after 2 weeks. Okay, that is important. Hello, doctor. Hello, honey. Can I do dentin sealing if I reach to the dentin? Can I use bond and prime? It's coming together from Dentsply. What I want to add composite over composite. So if you reach dentin, you do your dentin bonding. Just normal, regular bonding procedures in dentin. Don't mess up things. Just do your regular bonding. Okay. If you want to repair composite, to use Dentsply bond that comes with a primer and bond together, to be honest, you can. Nobody will die, to be honest. So actually, it's better to use unfilled resin without HEMA, but you can. With a very thin layer, dry it, and then you go. But it's not very expensive to buy unfilled resin or modeling resin, actually. To you, one more question. You positioned the perio probe on the end of bevel incisal side and not to the cervical side of the bevel. And from there you measure 0.5 millimeters. Rewatch again, okay? And then you see we have bevel and this is the end. This is defect. Here we have defect. So my probe gets at the very end of the tooth where my soft composite is, and then I make my 0.5 mark, and then I move my composite down and spread it towards incisal edge, okay, towards incisal edge, and then afterwards I bring some of dentin over the bevel. This is how it worked. Ayman, hello Maxim. Hello Ayman. I have missed the webinar, unfortunately. I'm sure it was great as usual. People used to say it was good. Have you discussed the freehand technique, or it was just about silicon index technique? Thank you. No, I didn't show freehand technique. I was showing silicon index, but I also showed how can you create silicon index in case if you have a big defect. So you will find very good tips and tricks. Great session, Dr. Maxim. Do you prefer using, thanks Vanula, do you prefer using either aluminum or diamond polishing paste to additional polish? I don't use paste anymore. With this twist material, twist rubbers, no polishing paste. Honey, we group from 12 doctors. Can we take course with you? Honey, always welcome. You can just come to our training center. To do so, you go to our webpage, which is en.belograd.com. This is our webpage. Okay, you can select module you want, or if you want to have personalized course with a group of people, you go to contacts here. Okay, and you may write down email, or here you can see our email, and here you can see the WhatsApp or Viber or Telegram from our course coordinator. You can write down directly and discuss possibility to come with a group of 12. We'll be more than happy to see you here, and believe me, our hands-on courses are very special, way more than even these beautiful online courses. And next, for a composite repair, is etching required or just bonding agent required? No need for etching. But if you do old composite restoration and you have, look, if you just repair the part of composite without touching patient's tooth, in this case you sandblast, you rinse it dry, then ceramic composite primer, then you go. If you touch patient's tooth enamel, so in this case you will etch enamel, you have to, and then you may etch composite just for cleaning, and then you will apply your adhesive to enamel, composite primer to composite, and then you go with your repairing. This is how it works. Which composite you are using for making very dark colored tooth if you want to avoid endo bleaching? Okay, you want to mask that. You may use a special masking agents, very opaque composites. From the one that I'm using is from Shofu. I think the name is Brilliant Opacker. They have two different opackers with the different shades, so that may block even metal. That may block even metal. So you can use this opacker, and then you can go with your layering procedures. Do you use also bleach cement color just to block the dark discoloration? Yeah, actually, this is the opacker. Yeah. Mohammed Ibrahim, thank you very much, Maxim, for your great effort. Greeting from Iraq. Thanks, my friend. Happy that you like it. Agusifa, thanks so much, Dr. Maxim. Great tips, and I really enjoyed the class. Thanks for your kind feedback. Khalil Ibrahim, what about your protocol of composite veneers? It's pretty much the same. Depends on the color that you would like to achieve. I think that we can actually do another masterclass about composite veneers to show different techniques. I think so. Let me think. Maybe we will do another online masterclass and I will show you step by step everything. Can you please answer this question? What is your advice generally about the loop light types? What loop light do you recommend? More brighter one with orange filter when applying composite, or more softer light like true color without the orange filter during application of composite? For every dentistry and direct restorations, to you, I cannot recommend you loop light because I don't use loops. You're working with a microscope and I can control the intensity of the light. But if your true light in your loops, if the true light of the loops is not polymerizing composites, so definitely this is the way to go. True light, because when you work with an orange filter, you saw during masterclass what happened. You can see nothing with the orange filter. So true light is way better, I think. More brighter with orange filter or for general dentistry? I think so. For general dentistry, you have to have bright light, especially for preparations, caries excavation, for endo, and softer lamp, which you can use without additional. I'm not sure if the softer lamp will not polymerize composite. This is what I'm not sure, to be honest. Shaho, thanks Maxim. Do you remove proximal contact in composite veneer? It depends on the shape that we would like to achieve, and basically it depends on the case. I cannot give you a strict answer, yes or no. I can, it depends. Sometimes yes, sometimes not. Son, thank you very much, doctor. Thank you. Son, yeah, Shabo, if yes, how much need to create natural view in bleach color? Cannot give you an answer. Depends. Son, yeah, this is correct pronunciation, I think. Are we going to have record of this part of Q&A and answers? Sure, you will have everything. A main session and Q&A session, it will be recorded, so you'll be able to have it for 14 days. Vinutha, thank you very much. Could we do composite immediately after vital bleaching or non-vital bleaching? I think you have to wait about 10-14 days better after bleaching. Halil, that will be great. An online course about composite veneers. I think let me think. Maybe we'll do something. To you, thanks again for your kindly answering the questions. My pleasure. My pleasure. I enjoy the session, and then actually I enjoy answering that questions. His connection is okay? Because in my side it's not okay, I think. Let me check again. Something went wrong. Maybe my internet is not. Yeah, good. So yeah, we're done. A lot of questions. Wow, thanks for that interaction. Actually, it was good. 53 comments, pretty good. By the way, don't forget to share this session in your Instagram stories. We will repost. Okay, and what I want to say is that I'm really happy that everything that we do finds great feedback from your side. We are very happy, and I would like to thank you again for watching us, for participating in our programs. We'll be more than happy again to meet you here in Kiev, Ukraine for our hands-on courses, because it is the next level of education, much more efficient, and I would like to say you to be healthy, wealthy, and may the dental force be with you guys. See you next time. Bye-bye.